Sure.
And we are very much grateful to Mindray India for giving us this platform as usual, as they always do for our Kerala chapter. And they do a wonderful job, as we all know. Without any glitches, things go well. So we are very much thankful to, on behalf of Kerala chapter, thankful to Mindray India for their support.
Thank you so much, ma'am. It's a pleasure, as always. Is the screen visible, ma'am?
Yeah, it's visible.
Okay.
So,
Parnyamadi, I'll just keep on moving the slides.
okay.
Yeah.
So our speaker for today is Dr. Meera Thomas. She is professor and head, Department of Pathology, Christian Medical College, Vellore. Can you go ahead?
This is connecting.
So
Can you hear
Dr.
me now?
Meera, yeah. Dr. Meera, yes.
Yeah. Can you hear me?
So she's just the right person to cover this topic. As you can see from her biodata here, she's professor and head Department of Pathology, CMC Vellore. She was part of the executive committee Dermatopathology Society of India. She conducted the first virtual dermatopathology conference under the Dermatopathology Society of India on January 2021. She's a life member of the Indian Association of Pathologists and Microbiologists. She's trained as a fellow at the Dermatology Hamburg, Germany, and worked as observer in Boston Medical Center Dermatopathology Division. She has 60 publications in national and international journals, and she's given 52 talks. And her field of expertise is dermatopathology and head and neck pathology. So, Dr. Meera, welcome on behalf of Kerala chapter. We extend a warm welcome and thank you for accepting our invitation as a speaker and finding time for us. So over to you, Dr. Meera. We have a lot of queries regarding cutaneous lymphoproliferations, which we hope you will be throwing a lot of light on. Welcome. Over to you.
Thank you, Nina. Am I audible?
Yes, ma'am. I am stopping my share and will leave it to Meera ma'am now. Thank you so much.
Thank you, Nina, for that introduction. It is a privilege to be part of the Kerala chapter. I did my MBBS in Cotton Medical College, and it always gives me fond memories of coming back to Kerala. And I hope I get to this topic. If I can share my screen. Visible. Screen.
Full screen, please.
So what I'm going to do basically is just a brief how
Dr. Meera, you're
cutaneous.
breaking off a bit. I think there's some interruption in your voice.
I'll switch off my video and then we hope it's better then. Now, am I clear? Is it better?
Not, there's no much difference now also.
Can you hear me now?
Yes, I think it's better.
Okay. So, this is lymphomas are the second most common form of extranodal non-Hodgkin. And you have a wide spectrum of clinical, physiological, and clinical side. You can have primary cutaneous lymphomas and purely in the skin with no other organ being involved for about 6 months. Second, when you have cutaneous infection, you have a cutaneous right? When there is a noodle or an organ being involved within 2 to 3 months of the cutaneous infection, or there's a primary lymphoma already present and a cutaneous lymphoma comes after that. Primary cutaneous where it talks about primary cutaneous CD30 positive for proliferative disorders, SPTCL. Then the old ones that talks about primary cutaneous types and the ones not otherwise specified. Then they have the extranodal T-cell lymphoma and the cutaneous low-grade B and the high-grade dormancy primary cutaneous diffuse large B-cell lymphoma, which forms most of the cutaneous B-cell lymphoma. In 2020, there have been announced statements in which they have said you cannot put MS and cesarean together, cesarean cells. They've taken off the red types in primary cutaneous CPCLs and said there's only primary cutaneous lymphomas, which can be dermatopathology or
Madam, it's not clear.
Meera, you're breaking off.
very not clear.
Yeah, it's
No,
not
madam.
clear.
Okay, let me see if I can get change my internet. So I just put the Reliance one, which I thought that was better. Is it clear now,
No, madam,
Okay.
again it's breaking.
or am I still regular now? I guess so.
Hello. Yes, Dr. Shiny,
Can you
any
hear
concern?
me now?
Yes, yes, the connection is not that much strong. So the
Yes,
voice is breaking, madams.
yes, that's true because
Now can you
even
hear me?
No, madam, again it's breaking.
Okay, I'll just go and take it from the another computer and do it. Okay, I'll just share it, start again from my computer.
Okay, ma'am.
Sorry for that. There is some connectivity issue. Hopefully, it will be corrected.
Lobby. Can you hear me now?
Yes, madam, it's clear.
Clearer?
Yes, yes.
Okay. I'll just share my screen again. Huh?
Okay, madam.
Is it clear now?
Yes, yes.
Clear?
Yes, yes, yes,
Yes,
clear.
much better, ma'am, much better.
Okay. We're talking about the 2022 update. Let me
Madam,
just.
please put in full screen.
Just 1 second. Okay. Okay. In the 2022 update, they have taken off the rare subtypes and called it primary cutaneous gamma delta, primary cutaneous aggressive epidermotropic CD8 positive T-cell lymphoma, primary cutaneous CD positive small medium pleomorphic T-cell lymphoproliferative disorder. They've taken off the provisional and they've called primary cutaneous acral CD8 positive T-cell lymphoproliferation disorder. Is it clear to you? Can you hear me?
Yes, madam.
Can you hear me?
Yes, madam, we can hear you.
Okay. They've also got primary cutaneous marginal zone lymphoproliferative disorder and not a lymphoma. And they have produced, they've called lymphoid proliferation and lymphoma associated with immunodeficiency and dysregulation, under which you have the EB positive mucocutaneous ulcers. All those that is positive they put under that subtype. So if you look at the PTCLs, primary cutaneous lymphoma, most of them are T cells, only 20% are B cells. And of those which are T cells, 60% of them are mitosis conductors. And they are different subtypes. So how do you go about looking at the primary cutaneous lymphoproliferative disorder? You have to look at the ABCDE exactly like you would in melanoma. First, look at the age, the background, the clinical presentation, the differential diagnosis, and physiological and immunophenotypic evaluation. So we all know that MF and Fazari is usually seen in older individuals, ALCL and lymph node papulosis is seen in younger individuals, even in young children. These cells are usually seen in older individuals. Next is where does the patient come from? Usually a patient who is HTLV positive is more likely to have an adult T-cell lymphoma leukemia, which is usually seen in Japanese or somebody from Central America. In the Asians, you mostly have those which are EBV associated, like you have an extranodal phase, very common in our population than in the Western population. The next thing you ask yourself is the background. What is the immunological status of the patient? Whether it's associated with EBV, we all know that connective tissue disorders like SLE, Candida, or SPTCL, those who have borrelia, especially in Central Europe, they're supposed to have more tendency to develop marginal zone lymphomas. And many of the novel biological agents have capacity to produce lymphoproliferative disorders. Last but not the least, infectious pathogens have been associated predominantly with CD34 infiltrate, which can also produce pseudo-lymphoma. The C is the clinical presentation. If you have mycosis fungoides, you'll always look for lesions in non-photoexpressive. If you have any variant, you'll always look at the clinical scenario. Is it a patch, plaque, or tumor stage that you have? Folliculotropics are usually seen in the head and neck region, whereas those with vegetal reticulosis are seen on acral side. Those which are seen on the nose and the ears, you think of it acral CD8 positive granulomatosis flaxen Slack skin is typically seen as pendulous, uh, uh, pendulous lesion, predominantly in the axilla and the inguinal folds.
Madam, are you using the mic?
Pardon?
Do you have mic? Are you
I
using?
don't have a mic. I'm just using. You want me to use the mic because is there a background noise?
Yes, Miss, the voice is bit low.
Not loud.
Not
Can you
loud.
hear it now?
Yes, now it's.
Better?
Yes, it's better.
Okay, I'll do it. So generalized erythroderma, which many of the times we're asked to look at the biopsy, is usually associated with mycosis fungoides or psoriasis or erythematous eruption. So why do we need to know the different types? One is we need to differentiate between indolent, intermediate type, and aggressive types of lymphoma. The indolent ones are the MFs and the low-grade B cells. The aggressive ones are usually the NKT cell, plasmacytoid dendritic cell neoplasms, Sézary, etc. He comes to a differential diagnosis. Is it an inflammatory lesion or is it really a lymphoma? You need to differentiate it. You need to have those differences in your head before you decide it's a lymphoma. All lymphoproliferative disorders are not lymphomas. Something else which we can remember is, first of all, you look at the patient. Where is the lesion? If it's an epidermal or a subcutaneous lesion, it's more likely to be a T-cell lymphoma. If it is a dermal one, you predominantly have both the low-grade and the high-grade B, and the T and Ks, which are usually seen predominantly dermal with or without an epidermal type. So if you look at histomorphology, there are usually 6 patterns that we have. It could be epidermotropic, nodular, diffuse, perivascular, folliculotropic, or paniculotropic. The more common patterns are epidermotropic, nodular, and diffuse. So let's just go through a few of them so that you have an idea of what to look for when you see the different patterns. Mycosis fungoides is a prototype of an epidermotropic infiltrate, predominantly of small to medium-sized T lymphocytes seen in older adults which have fat, flaccid tumors. When they have a leukemic form, we call it Sézary, and there are at least 1,000 Sézary cells per milliliter. But you cannot call it MS unless you have a classical clinical correlation and a medication history to rule out other differences. Like I'll just take you through a few of them. Now, what do we do when what do we need to diagnose mycosis fungoides? The first thing you need is there lymphocytic epidermotropism or not? What do you mean by lymphocytic epidermotropism? That the lymphocytes are focused and go up into the epidermis in a manner that it's not haphazard. When it's haphazard, we call it exocytosis. When it's focused and goes along a linear manner into the epidermis, we call it lymphocytic epidermotropism. So usually it extends to the upper half of the epidermis and not just random all over. Usually you have haloed lymphocytes like you see here. You have lymphocytes along the basal layer of keratinocytes, slowly moving up into the upper layers of the epidermis. Many of them have perinuclear halos. They go in a focused or manner into the upper layers of the epidermis with hardly any sponges. We will not find many necrotic keratinocytes either. You may find an occasional one, but not too many keratinocytes. They have irregular nuclear membranes, like you see here, and abundant eosinophilic, scant cytoplasm with extensive perinuclear clearing. Here you have few of them in the lower layers, and then it goes into the upper layers. You can see the perinuclear clearing. The problem with this is you can see a Langerhans cell which looks exactly the same. So you need to discern whether it's a lymphocyte or a Langerhans cell. Usually the epidermal component is larger than the dermal component. In the dermis, you have fibroplasia and no edema. If you get phosphorus microabscess, which you see in about 40% of cases, then it's easy for us to call it microcytic fungoides. But it's not usually seen. This is a beautiful picture of multiple aggregates of atypical lymphocytes seen within the epidermis associated with dermal fibroplasia and targets extension of lymphocytes into the epidermis. When we do markers, especially in the early phase of MS, when the atypia is very mild and they look almost normal. Here you can see CD3 going all along the basal layers. Compare CD3 with CD4. Here CD4 is more, CD8 is less, and we have CD7 is reduced. When CD7 is reduced with respect to CD4 or 8, then you think of mycosis fungus. This is like hyperpigmented patches, erythrodermic like you see here, or hyperpigmented large cell transformation occurs in about 20 to 50% of the cases, where if you have more than 25%, we do think of a large cell transformation. In large cell transformation, usually you have less of epidermotropism. They have mutations with PDL1, which we can do, and that's useful therapeutically as well. Pagetoid reticulosis is a variant of MS, but the lesional cells itself are larger with ample cytoplasm and show pagetoid scatter in the epidermis. Lesions are usually solid phase, enzymatic, and erosive, and present at the extremities. But the IHC is exactly the same. If you look at this picture, what do you see? Can I have some of the audience tell me what they see? Do you see epidermal scatter or pagetoid scatter in the epidermis? What about the basal layer? Is there nice string of pearls appearance or tagging of lymphocytes along the basal layer of lymphocytes with some clearing? Do you see all that? So what do you think I should call this? Pagetoid reticulosis or mycosis fungoides? The lesion seen on the acral site. What do you think? Anybody? Give you 5 seconds.
You can
Pagetoid
raise
reticulosis or
your
mycosis
hand.
fungoides?
You can raise your hand.
Nobody knows? You want to put in the chat? What do you think? You can be anonymous. PGs, what do you think?
Or you can respond in the chat.
I don't have an answer. So I'll go to the next slide. What you see actually is aggregates of cells which also have pigment in them. Even though there's pagetoid scatter, this is actually an atrial lenticular melanoma, which can simulate a pagetoid reticulosis. The site is the same. You may have similar lesions. So it's very important to look for the pigment and to do markers. Whether it's merely a variant of MF or not. Here is a 17-year-old male who has tagging of lymphocytes along the basal layer of keratinocytes with clustering, with some clustering, and the cellular
Madam,
clearing.
again, your break.
Now is it clear?
And now is clear. This position is clear, madam.
Okay. The 17-year-old male, we don't know what the inner profile is like. he's got hyperpigmented macules. Even the duration we don't know. What do you think the differences should be? It's an Asian male who's got hypopigmented macules. What do you think the differences should be? What differences should you think of? Or what should your clinical colleagues tell you? Anybody? I would think of anemia. I would think of a vitiligo. I would also think of a hyperpigmented MF. Early lichen sclerosis, etc. is also a difference when it comes to the H&E picture, right? But then they have different heights. All of them can be 3 positive. All of them can have lymphocytes tagging the basal layer of keratinocytes. Both in early vitiligo and LSAT, you can have CD7 positive, but CD7 can be lost as well. In hypopigmented MS, usually CD7 is lost, and you have 4 or 8. So if you look at this mark here, you can see 3 is positive along the basal layers, 8 is positive, 4 is lost, so it's 7. So is it a hypopigmented MF? Let's look at the clinical picture. That's something which we didn't see, right? Does this look like hypopigmented MF? Doesn't really look like hypopigmented MF. No? Clinically, it looks more like vitiligo. But I don't know. So what do? I go and ask for, which stain would I ask for? Anybody? Which stain would I ask for? You have this nice article by L. Dorothy, which talks about melon A being used to differentiate inflammatory vitiligo versus mycosis fungoides, because histologically, both of them can show epidermotropism. There can be loss of there can be lymphocytes tagging the basal layer of keratinocytes. You can have viral fibrosis that happens on vitiligo, but you usually have decreased number of melanocytes. Actually, we didn't look at the H&E picture clearly enough, because here, if you look, there is decreased pigmentation of the basal keratinocytes, and if you do a melanocyte, it's totally lost on IHC. So this was an inflammatory or early vitiligo. So whenever you have an atypical epidermotropic lymphoid infiltrate, first you look at what age it is, exclude inflammatory dermatosis by looking at the amount of spongiosis, necrotic keratinocytes present or not. Then you go to your histology and ask yourself, is it CD4 or CD8? Is there loss of CD7? Does the clinician think it's MF? If there's a very low threshold for MF by the clinician, you always ask for a TCR. And then check for any folliculotropic epidermotropism which is present. And only if the clinician says, yes, high suspicion for mycosis fungoides, go ahead and do your markers and exclude mycosis fungoides. So the next pattern that we see is the folliculotropic or folliculocentric pattern, where you have, in this patient, where multiple phases of facial papules on the face of 5 months duration with no systemic symptoms. What do you see here? We see the epidermis is unremarkable. There is hardly any tagging along the basal layer. Dermal infiltrate, which is perivascular, perifollicular, with cystic degeneration of the hair follicle, some mucinous material inside it. So it's a follicular mucinosis. You also have inflammation around some sweat glands. What other infiltrate do you have? You have some eosinophils scattered, and the lymphoid infiltrate looks atypical too. They're slightly larger with irregular nuclear membranes and scan to moderate amounts of cytoplasm, right? And these infiltrates seem to be going into the epidermis in a targeted fashion with only minimal spongiosis. So this is folliculotropism. So this is what you see in lichen planopilaris. What would you find? You'll find necrotic keratinocytes. If it's pseudolymphomatous folliculitis, you'll have destruction of hair follicles. We are not seeing any destruction of hair follicles. What we are seeing is cystic degeneration in the center with a lot of mucinous material. If it's follicular mucinosis, the lymphoid infiltrate is not atypical. Here we have atypical lymphoid infiltrate. If it's lymphomatoid papulosis, you'll have a totally different clinical scenario. IHC done shows very clearly 3 is positive, 4 is positive with scattered CD8 positive cells in the background with loss of CD7. There are a few scattered 30 positive cells, but just they're activated immunoblasts. So what is the differential here? This is the polyphenotropic mycosis fungoides, which needs to be differentiated from its mimic because it will have a poor response to therapy. The next pattern that we see is the perivascular pattern. It's usually seen in CD30 positive lymphoproliferative disorders, which can be either ALCL or lymphocyte papulosis. Am I clear to all of you?
Yes, madam. But in between, there is some break.
Okay, is it okay now?
It's okay now.
Okay. So distinction is basically based on the histology, clinical presentation, and the course of the disease. In lymphocyte papulosis, you have waxing and waning of lesions, usually seen in the trunk and proximal extremities, can be seen in the third and fourth decade, seen all over except usually mucosal involvement of the. It can be associated with eosinophilia. Only 5% of them do progress to lymphoma and can be associated with both MF and Hodgkin's lymphoma. Important to diagnose it because they have an excellent prognosis compared to ALC. There are 6 different types described. The first type, lymphocyte papulosis type A, usually has a mixed infiltrate, which is predominantly perivascular, superficial, and deep perivascular. Here's slightly perineural with lymphocytes, histiocytes. If you look at the higher power, you'll find some large cells which have got indented nuclei, prominent nucleoli, and abundant eosinophilic cytoplasm, sort of like the classic cells that you'd see in ALCL. But that's just few of them that you see. If you do a CD30, they are positive. You can have a few CD20 being positive with a very low mid-value. That is lymphocyte papulosis type A. In type B, you have an epidermotropic or a band-like infiltrate with a few scattered B cells. In type B, you have many CD30 positive 30 positive large atypical cells, except the history is waxing and waning of lesions, which you would see. Unlike ALCL, which is a progressive lesion with a very short history. Type E is when you have perivascular, interstitial, and type B and epidermotropic infiltrates seen, which is predominantly CD8 positive, where you have the typical lymphoid infiltrate with irregular nuclear membranes. You can mistake it for mycosis fungoides, but the history is very classic and they usually resolve without any treatment, unlike MF, which goes on and on. Type E is the one where you have perivascular or angiocentric infiltrate with superficial and deep perivascular angiocentric. The last entity which we see is type, I call it type S. It's the one which has a DUS-P22 mutation, where you can have epidermotropism with periadnexal. So you have some epidermotropism with predominantly perieccrine and perivascular infiltrates with this atypical cells. They are CD30 positive with a low mid-1, but you find that they have a class which can be seen in this particular patient of ours is doing well without any treatment for the last 8 months. So just for you to remember, type A has a wedge-shaped infiltrate, it's a mixed infiltrate, superficial and deep, with neutrophils, lymphocytes, histiocytes, with scattered 30 cells. Type B is usually lichenoid, with some epidermotropism of CD4 and type C looks exactly like ALCL except a history of vaccine and drainage. Type B is a H positive lymphoproliferative disorder with a dense dermal infiltrate, but the lesions regress and recur again. The last type usually has a DUS-P22 mutation. They do well, though they look very aggressive because of the eccrine and perivascular infiltrate that you see. Here's a 55-year-old female with multiple nodules on both legs of 4 months duration. Short duration, ugly looking lesion, but you have the deep perivascular infiltrate. There's some epidermal crusting. You look at the infiltrates, they're all large cells with vesicular nuclei, indented nuclei, prominent nucleoli. Some of them even abundant eosinophilic cytoplasm. Some of them are even multinucleated. They look very bizarre and ugly. This is classic where you have CD30 positive cells being present in more than 75% of the lesion. Primary cutaneous ALCLs ALK negative. Though you do have systemic ALCLs which are ALK negative and have a bad prognosis, primary cutaneous ALCLs have a very good prognosis. So whenever you have a purely epidermotropic infiltrate, the markers that we do are CD3, CD4, CD7, and CD8. Whereas if it's a dermal or subcutaneous infiltrate, you do 3, 20, 30, MIB1. Then if it's 3 positive, you do 4 and 8. If it's primarily 4 or 8, if it's 20, you look at the MIB1. If it's more than 40, it's high grade. We do markers for the BLBCL. That is CD10, MUM1 and BCL6. Whereas if it's low grade, you think of low grade B-cell lymphomas, primary cutaneous, the usually marginal zone on follicular centric. Mantle is very, very rare in the skin. And then for that, you do 5, 10, and 20. Now, if it is 4, the first thing you do is this is CD30 positive and you rule out an ALCL. If it's CD30 negative, you usually do a CD25 or a CD56. CD25 or ATL, that is adult T-cell lymphoma. If CD56 is positive, then you do an EBV to exclude an NK T-cell lymphoma, the nasal type. If EBV is negative, then think of a gamma delta T-cell. If it's CD8 positive lymphoma, it's a CD30 negative, do TIA granzyme B. If it shows epidermotropism, it's an aggressive CD8 positive lymphoma. If it is only in the subcutis, then you think of SPTCL. Now, in this particular patient, it's an older patient, it's not known, with multiple nodules on the leg. You have large cells which are 30 positive, as negative. This is a P30 lymphoproliferative disorder, and it's an ALCL. Why? 1, because the history is short, no vaccine and waning, unlike lymphoid papulosis, which would show waxing and waning. Here's a 36-year-old gentleman who has a lesion on the nose, which is hyperpigmented, hemorrhagic, and crusted. They had multiple differences, both infected and lymphoma. Histologically, what we saw were sheets of atypical lymphoid cells, which were unlike the field of muscle, large cells, different spinal matches, abundant different cytoplasmic with activity, with a lot of perivascular and angioinvasion with fraction of the cell. And we also see a lot of structure. You look at it, the cells themselves look very hypochromatic and such. So sometimes it's in the because inflammation remember, especially if it's things, what sort of action do they do? Very vascular and nodular. You remember what sort of nutrition you get? You usually get it's predominantly dermal, could be either root or empty. So we go back to our primary, to the electrical cell infiltrate. 3, 20, 30, and 1. So it's finding 3 positive, 20 negative, 30 negative with a high energy. So when you have 3 positive, 20 negatives, when you get 4 and 8, you have 4 positives, 8 negatives, 20 negatives, and high mid-one. When you do the positive, but now you've got 2 different. It's an NKT cell lymphoma or is it a gamma delta T cell lymphoma? Both are potential. So then you do review. Here we use the LMP1 positive. Here exam can be also positive. So if you look at the ABCD, you have a young boy, radiation, with a trusted lesion of the nose of short duration. Clinical differential starting from inflammatory lymphoma, which is shown in
Madam,
yeah.
Madam, it's so much disturbance. So someone is saying that it's not because of the net issue, maybe because of your microphone issue.
Now can you hear me?
Yes, yes. In between, it's
Okay,
clear.
maybe the microphone is I kept it away from you.
Okay,
But
okay. Madam.
now it's yeah. I'll do it like this.
Yes, madam, it's very clear.
So when you have differential of an angiocentric lesion, which is CD4 positive, high MIB1, CD56 positive, and KT cell. NKT cell lymphoma, gamma delta T cell lymphoma, with a differential to be considered, but we found EBV positive. Then you get us externally, NKT cell lymphoma. Now it's just called NKT cell lymphoma. We filled out that externally has been taken off in the new application. Why is it important to diagnosis? Because usually the present in advanced stage 3 or 4, and have a poor presence. Another tumor which you should be aware of. Okay, I'll just skip this. I'll just go to one.
Madam,
after.
again not clear.
Okay, shall I skip this and go to the next one? Can you hear now?
Yes, madam. Now it's clear.
Okay.
I think please maintain that position only.
Okay. Sorry. Here's a nodular
Okay.
diffuse infiltrate with a Gren zone. And on higher power, you find they're all hypochromatic. Still higher power, they don't look that hypochromatic. They look like large cells with prominent basophilic nuclei. Abundance here to mildly pale eosinophilic cytoplasm, which seems to be going in between the collagen bonds. So what does this look like? Anybody? This is easy, right? Is it a low grade or a high grade lesion? What do you think? Yes, somebody has said.
High grade.
What do you think? Low grade or high grade? Looks like a high grade lesion, no? So some mitotic figures are also there. Yeah, it's a high grade lesion. So now the next thing that we do is the markers. This is 3 negative, 20 positive with a high mid one. MUM1 positive, BCL6, BCL3 positive, CLIC negative. This is a diffuse large B-cell lymphoma of the leg side, which should be differentiated from primary cutaneous follicular central cell lymphoma, which can have a diffuse growth pattern, but that is usually negative lymphoma. And there are no follicular dendritic cells present with large B-cell lymphoma. Next, coming to the panniculitic lesions, panniculitic lymphoproliferative disorder. An 18-year-old female who has got a nice infiltrated erythematous lesion on the thigh. What do you see? What is the infiltrate like? Is it septal or lobule?
Madam, not clear.
Is it septal or lobular? What sort of infiltrate is it?
The responses are
more
coming
long.
septal.
Here for me, the septal looks clean in the lobules, right? The infiltrate is in the lobules. If you look on the higher part, what do you see? You have atypical cells lining the fat spaces with under higher part. You find hemophagocytosis. You see that? You have cells which have ingested other nutrients lining the fat space. This is commonly seen SPTCL. But all SPTCL, not only SPTCLs, lupus also can have a similar histological symptom. So what special stain would you do if you think of lupus versus SPTCL? Any histological special stain you need to ask for? What histological special stain did you ask? Anybody? Special stain. If you're thinking of lupus, what stain will you ask? Will you ask for a mutant stain? This particular patient had no mutant. Go back and check. Again, the atypical cells lining the fat spaces. We do IFC, we'll find 3 is positive, 8 is removing the fat spaces, 4 is seen only in the interstitium of the panic. Statistic is negative, mid-1 is 5, which is an assessment. Important to differentiate lupus from our sequential gamma delta T-cell lymphoma and an NK lymphoma. NK T-cell lymphoma can be in the panniculus with extension into the dermis and is usually EBV positive. Gamma delta T-cell lymphoma also is seen in the panniculus, can be seen lining the fat spaces, can be CD8 positive. PCR gamma delta is positive, alpha beta is negative, EBV is negative. They can also show angiotropism. If you don't show angiotropism, they can look exactly like. How do you differentiate it from lupus? We find that all the changes that we see in lupus can be seen in SPTCL as well. But with the CD20 positive aggregates.
Madam, not audible. Please adjust your mic position, microphone.
Now, can you hear me?
Yes, madam. Now it's clear.
Okay. So in lupus, we will find CD20 positive aggregates and plasma cell aggregates, but it is not usually seen in SPTCL. Also, plasmacytoid dendritic cell flower. Dendritic cell that is CD123 usually seen in clusters in which and seen separately focally in SPTCL. The last reasons I'll say you today, before you tell me the answers, is a 50-year-old female who had limb swelling and abdominal swelling. It is very epidermis. What do you see in the epidermis? Normal, abnormal? Epidermis and dermis? It's normal or abnormal?
Normal.
The normal epidermis, normal dermis. Subcutis, what do you think? Is it a lobular paniculitis, septal paniculitis, or no paniculitis?
No paniculitis.
No paniculitis. Okay. So what do you think are there in panic? But proliferated blood vessels?
Some forming macrophages.
Normal, right? Almost normal.
Mhm.
But remember what I told you? Not only LOPA, you also always have to go on the hyper. What do you see on hyper? You see, again, proliferated blood vessels. Still higher far, if it is 40x, this is what you will find. There are some cells only within the blood vessels, which have irregular nuclear membranes, large cells, fine synapses, can deposit among the started last time. Some of them are also showing hemophagus mutations. Consider. So when you have hemophagus psychosis, with cells only within the blood vessels, what's the difference? In the BDs, I'm telling you, this is what we got. I said we got this. SPCL, ecstatic carcinoma, melanoma, or a reactive angioendocrine. We did markers, which was negative. CD3 was negative. F1 was high. CD20 was usually positive. Non-1 positive. Yes, yes, Meera, I also thought of SPCL, but it didn't fit me. So this 20 positive opposite was PCL2 and number positive. Okay, intravascular disease, large just for you to remember, always look for the ones which you know and making the therapy. You will miss the diagnosis if you don't look within an hour. I think I have overshot my time, right? You know, I'll say time for one case. Can I discuss one case and then stop?
Yes, madam. You can continue.
Just the last one.
Madam, time is not over.
Not
We have time.
we have
Yes.
time. Huh? Okay, then I'll go to that. So just a few cases which I thought
Madam, please maintain the position of your mic.
now can you hear me?
Yes, sir. Now it's okay.
49-year-old male with skin lesions of the body for 2 years. He recurs, relapses, then he resolves. There is partial response to some treatment. He has new lesions on the face. Then there are succulent papules and nodules. Then again, he recovers from it. He doesn't have any pallor or lymphadenopathy. What we see is a diffuse perivascular and interstitial infiltrate with epidermal focus. With irregular nuclei, irregular nuclear membrane. So what are things which we can talk about? This is, what are your differences in the two? I'd like you to tell me. I've been talking to you now. I'd like you to tell me what are the differences you will think of when you have dermal infiltrate with epidermal focus. Anybody? Would you like to consider any differences? Lymphomatous papulosis. Anything else? Yes, the history of a giveaway, right? When I tell you that there is waxing and waning, the first thing you should think of is lymphomatoid papulosis. So for that, you usually do with epidermal infiltrate into 3, 4, 7, 8. And here you have 3 positive, 4 negative, 8 positive, 7 preserved, and dermal infiltrate is 20, 30, Nib1. This 49-year-old immunocompetent patient with recurrent relapses with 8 positive, 30 positive, 56 negative high Nib1. It was actually 30 positive lymphocyte papulosis is actually type B, lymphocyte papulosis type B. Okay, that's the one which I actually told you earlier. 60-year-old male is actually one of our staff letters. He came with a swelling on the right cheek for 1 month duration. What's the field? Then diffuse infiltrate all along the dermis, going into the subcutis as a modular infiltrate into the lobules and the what does the infiltrate look like? Large cells with irregular nuclear membranes, vesicular nuclei, prominent nucleoli. Some of them look like the classic CD30 positive cells, right? They look very irregular and ugly. So what would you do? So what are your differences now when you see such an image? What would you think of? Would you think of ALCL? Yes? In your differentials is ALCL there. I thought ALCL. And there are a lot of mitotic figures too. So definitely hydrate. So pandermal atypical lymphoid infiltrate hydrates for me. And because it's dermal, I would do with 20, 30 minutes. I did that, UV3 was positive, 20 was also positive, aggregates and going down. It's CD30, more than 75% of the large cells were CD30 positive, but the MIB1 was low. So now what is it? What do you think the diagnosis is? Here you've got an infiltrate, which is 3 positive, but 20 positive deep down. CD30 cells are more than 75% and MIB1 is low. Maybe I should give some markers, right? So my differential was, is it an ALCL? Or is it a CD20 positive lymphoproliferating disorder? So I did CD4 and CD8 because 3 was positive. CD4 was definitely more than CD8. So you have CD4 positive, CD30 positive. Infiltrate, which is predominantly in the dermis, going into the subcutis, it could be B, T, or NK cell. So if we look at the WHO, it's either a CD30 positive lymphoproliferative disorder, not an LYP because it's got a short history, or it could be a cutaneous B-cell lymphoma, which is predominantly low grade. We can rule out an MF because again, short history, right? Could be an ALCL or any of the low grade B-cell lymphoma. Older individual, immunocompetent, 1 month history. So we went ahead thinking it was these two, either low grade B or an ALCL primary or secondary. Alpha is negative, now it's negative. So it's a PTCL, primary cutaneous, anaplastic large cell lymphoma, but you won't have so many B cells, right? So what do you do with that? So it's a B cell with a lot of 30 positive cells. If you look at the low grade B cell neoplasms, primary cutaneous marginal zone lymphoma is negative for everything except histology. Follicular center cell type lymphoma, low grade B cell lymphoma, is positive for cutaneous lymphocytes and B-cell. Whereas chronic lymphocytic lymphoma is usually positive for lymphocyte, CD23 and B-cell. Mantle cell is positive for cytokine. 5 positive, 23 is positive, BCL2 is positive, 10 negative, cycling B1. We did kappa lambda telling us it's a polyclonal infiltrate. Now, if you look at again the differences of the low-grade B cell neoplasm, in our case it's positive for 5, 23 and BCL2. So very similar to your chronic lymphocytic leukemia. Therapeutics is clear. There's no anemia. Patient is absolutely well except that for that single lesion. So now what do? We were informed this is a staff close relative. So we didn't know what to call it. So then we went back to the patient, asked the clinician, give us some of this. All we know is the 1 year, month is happened. Did anything happen? Did the patient take any drugs? Was there any other history that you can tell us before this lesion appeared? So then the patient told the clinician, yes, there was a history of bee sting 3 days prior to the lesion appearing with associated symptoms. Something else we found was there was some spongiosis in the epidermis. Insect bite reaction can produce a lymphoid infiltrate exactly like a lymphoid. So it doesn't fit in with any of the types in WHO. Always go back to your clinic and check whether there is any history of insect bite, any drug being taken. Last case is a 30-year-old female who's got joint pain with ANA being negative, pancytopenia with large plastic plaques on the legs. No interface change. Dermis is almost normal with a lobular panicle infiltrate with some fat necrosis and beanbag cells or hemophagocytic cells seen lining the fat. It's a lobular lymphocytic panicleitis with atypical cells. Differentials include both lupus, SPTCL, gamma delta, NK, and atypical lymphocytic. The epidermis is normal. There is mild mutation seen, especially in the subacute. And we did markers. 3 was positive, 20 and 30 were negative, with the MIB1 being about 10 to 20%. CD8 was lining the fat spaces, CD4 was the interstitium, 56 was negative, granzyme B was positive. So this was not a lupus, not an NK T-cell lymphoma, or a gamma delta T-cell lymphoma. It was either SPTCL or atypical lymphocytic panicleitis, which is usually between an SPTCL and lupus. There is an article by Leon J. Weil who says that clusters of plasmacytoid dendritic cells, if you see them, it's more likely to be what we found was very focal CD123 positive plasmacytoid dendritic cell. So we find it out as a typical lymphocytic panicleitis flash. Case was doing well. So to summarize, the diagnostic approach to cutaneous lymphoproliferations evaluation includes the ABCDE, which is age and background, clinical data, differential diagnosis, HME and IMC. For epidermotropic lesions, we do 3, 4, 7, and 8. And for dermal, we do 3, 20, 30, and MIB1. Then, depending on whether it's 4 or 8, go ahead and do 30, 56. If it's 20, decide with high grade or low grade. Remember, the common ones are diffuse large B-cell lymphoma. Always remember, clinically correlate, your best friend is because drug-induced etiologies, insect bite reaction, and autoimmune disorders can mimic lymphoproliferation. Thank you.
Thank you, Dr. Meera, for that excellent, wonderful, elaborate and session on cutaneous lymphoproliferations and the challenges that we face. So we can have questions now. You can either unmute and ask, or you can put it in the chat box.
Namrata, please unmute all the participants.
Sure, Dr. Saini.
Dr. Meera, just one question from my side. When you
Sure,
think
go
of
ahead.
these, can you hear me, Dr. Meera?
I can hear you. I can hear you.
So when you consider those hypopigmented lesions, hypopigmented MF, you said vitiligo, and PLC will also be there in the differential pityriasis lichenoids.
PLC also can be seen, but usually in PLC we see a lot of extravasated RBC. That sort of helps us. And necrotic keratinocytes are also there, usually, but not always.
Hmm.
They can be hypopigmented.
Yeah.
you know,
Clinically, they look the same, isn't it?
Right.
This
They can
PLC
look different. They can look different.
Hmm.
But just that, some of the differences, and they're usually CD7 positive. With extravasated RBC, some necrotic keratinocytes,
Right.
that is the only way to differentiate them. But then, like I said before, your clinician is your best friend. If the clinician says doesn't fit in with MS, more in favor of PLC, I would say I will just say cannot be excluded. Mitosis fungoides cannot be excluded.
But sometimes they put the ball in our court.
Many a times happens. But I always depend on CD7 for that, CD7 and CD5. You'll see usually 80% of the time, sorry, 90% of the time, CD7 positive. It's not CD7 negative,
Okay.
like you'll see in
Right. And another question is, you mentioned about Melane immunostain for vitiligo.
Yeah.
So, I mean, what if you do a Mason Fontana spatial stain?
The Mason Fontana helps you only when there's a decrease in pigmentation. Both if there is no decrease in pigmentation, but you find the number of melanocytes are increased.
Okay.
That's
Okay.
when you need a melanin. If it's a fair individual, they will usually have only mild pigmentation all along the base. If it's a dark skin patient, you don't have a problem at all. Then you can do a Mason Fontana, and then you can say, leukoderma or a Richard. Sometimes what you find is you have those lymphocytes sitting there, and looks like melanocytes. Patchy. I have seen Mason Fontana, which has been mildly decreased, but not really decreased. So I was hesitant to call it vitiligo. Then I go ahead with the melanoma.
Okay. Okay. So it's not very specific, isn't it? Mason
Not
Fontana.
Not
Okay.
enough.
Right. Okay. So you need to know the melanocytes precisely.
Number of melanocytes.
Number of
Usually
melanocytes.
they say about 60-10 for every 100 centimeters.
Okay. And they need to be completely absent to call it vitiligo.
Correct.
Okay. Right. Thank you.
I'm so sorry for the bad quality of the presentation.
So let's have further questions from the audience.
Madam, just one doubt. How to differentiate this Langerhans cell from MF cerebral form cells, the typical cells of the MF?
Not on histology. Histology, they both look exactly alike. You have to do CD1 or Langerhans. You cannot differentiate them. They look exactly alike. And that too, especially at that site. If they are lying in clusters, yes, you can sort of say. But sometimes when they're lying alone, very difficult to differentiate them.
This atypical cells in the MF, is it that much atypical, madam? Usually we
Early
don't.
MS is not atypical at all. It
Means
looks
that
very
irregular
normal.
contour is it seen
The
always?
irregular contour is not seen in early MS. It is seen later. So they will look very typical. So unless your, how do you say, your antenna raised so high, you will miss out in MS when you see tagging. The corollary also is there. Lichen sclerosis, especially in young children, you see tagging in early lichen sclerosis, etc. So unless you have the clinical picture in your head, you will miss out and call it MF, especially in young children.
Can you just explain that IHC pattern in MF? It was not clear at that time.
Okay.
When you...
Okay. So usually in MF, CD3 is positive, either CD4 or CD8. There are very rare cases of both being negative. Usually it is either CD4 or CD8. Hypopigmented MS is usually CD8 positive, and the others are CD4 positive. CD7 is usually lost or decreased in mitosis fungi. Whereas in the case of inflammatory disorders, CD7 and CD5 are secured. In mitosis, it is lost or decreased, markedly decreased. So that's how you differentiate MS from vitiligo, LSAT, PLC, and even drug reactions you can have tagging along the basal layers. Very rarely, lichen planus can show tagging. But remember, if you see lot of necrotic calcium you should never call it MS. There are articles which tell you if you see one or two necrotic calcium don't hesitate to call it MS. I tend to err on the side of caution. I always say it cannot be excluded when I see necrotic calcium or more downstairs.
So, madam, then in normal inflammatory condition, which is usually CD4 is more than CD8.
Usually,
No.
CD4, no. Usually, in normal inflammatory conditions, CD4 and CD8 are the same. The ratio is 3:1 is almost always preserved. If it's more than 3:1, then you start thinking evidence.
Madam, it's more than how much?
Usually, 2:1 or 1:1 is the ratio that you usually see between CD4 and CD8. In the epidermis, don't look at the dermal incisive at all. Look at only the epidermal incisive. And that is in the epidermis only along the basal layer of keratinocytes. Not the moment like Langerhans cells, histiocytes, all of them will be positive to CD4. So those which you see above the basal layers, unless you see those same cells on histology, don't count them. Okay, that's very important when you do a marker.
Madam, not clear. It was not clear. Just
Okay.
can you repeat?
When
Mic.
you
Mic.
CD4 can also stain
Yes.
Langerhans cells. Histiocytes are also positive for CD4. So then they go up when you see lot of CD4 cells positive in the epidermis. Okay?
Okay.
So don't look at the dermal infiltrate at all in MS unless you're looking at tumor stage of MS. You will only look at the epidermal infiltrate and look predominantly along the basal layer of keratinocyte. Okay? So there in MS, along the basal layer where it's tagging, CD3, CD4 positive, CD8 negative, CD7 lost is what you would usually see. CD4 can also be positive for Langerhans cells and histiocytes. So don't overcount the number of CD4 cells. That's what I'm trying to say.
Okay. Thank you, madam. So any questions from the attendees?
Dr. Meera, regarding those Langerhans cells that you mentioned, usually we see these Langerhans cell microgranulomas in spongiortic dermatitis. And we recognize them because they form these small aggregates.
Correct. But you also have aggregates of Langerhans cells in tumor stage of microsis.
Okay.
But there is no spongios. That's the main
Yeah.
difference.
Okay. Right. Okay. Absence of spongiosis makes it more likely to be.
More likely to be.
Yeah. But then you say that you get Langerhans cell microgranulomas also in MF?
Usually they say in late stage of MF you can get aggregates of Langerhans. There are many articles that have come out saying aggregates of Langerhans cells. So they're supposed to be pathognomonic of allergic contact dermatitis.
Yes.
You can also see them in later stage of MF, but without spongiosis.
Without?
Without spongiosis.
Spongiosis, yes. Right. Okay.
And spongiosis should be less than the lymphocytic infiltrate in the case
So-
of MF.
Okay, so you have a portier, you feel there is a portier microabscess and you're in doubt whether it could be Langerhans. So do you always do a CD1A?
We don't do CD1A because if we have 3 positive and 4 positive, then it's more likely to be lymphocytes than
Yeah.
Langerhans.
3 positive. Yeah, right.
Because Langerhans cell will never be CD3 positive.
Okay.
That's why we always do CD3. Because some institutes tell us, why do you want to do 3 and 4? But mainly, unless you do 3, you don't know whether you're picking up the right cell.
Yeah, that's true.
And then one doubt, madam, the CD30 positive activated lymphocytes also 30 can be positive. So does that create a doubt?
Correct.
Uh,
So that's when you need your clinician as your best friend. When you have lots of positive, either T cells, B cells, any activated T or B can be 30 positive. So even, like I said, insect bite reaction, drug reaction, a whole host of them can be 30 positive. So that's when you need your clinical colleagues to tell you what is the clinical history like before you say, call it lymphocyte.
Shani, can you read out questions if there are questions in the chat box?
Namrata, I think there are no questions are seen now.
I think,
ma'am, only one question is there. Some number is there for CD4 8. Which one is more specific for MF? That is one question.
So that is, if you have for MF, the markers that we do are CD3, CD4, CD7, CD8. So if you have CD3 lining the basal layer, look only at the epidermis. Don't look at the dermal infiltrate. CD3, CD4 positive, CD7 reduced or absent, more likely to be MF in the correct clinical context with a patch, plaque, or wound. Okay? If that particular history is not there, you cannot call it. That's very important to remember. Because you can have the same IHCC even in other conditions. But if you have 7 reduced or absent, 4 positive, 3 positive, or 8 positive, 3 positive, 7 reduced or absent, in the right clinical context, MF is a likely histological problem. So they may just need some two-hour treatment or just follow-up because they go on for about 10 years before they turn into treatment.
And Dr. Meera, a related question to that, like you have a great difficulty in differentiating inflammatory versus MF. Okay, in that scenario, how do you do clonality studies or does anything help really?
Clonality doesn't help at all because even lupus can be clonal.
Yes. Right.
That is the biggest issue which we face. So that's why I said you have to look at all the investigations done by the patient, which the clinician never seems to understand why we need to know everything. We need the full clinical history. You know, the age, when it started, what was it like initially? Was it just a patch, hyperpigmented, hypopigmented? So we always do a PAS whenever we see epidermolysis. There is usually parakeratosis. Usually, I emphasize usually, because sometimes you don't have parakeratosis. Usually, what we say is parakeratosis, epidermolysis, no or mild spongiosis, no or very occasional necrotic keratinocytes, and the IFC. That is 3, 4, 7 reduced, 8 reduced, or 3, 8, 4 reduced, 7 reduced. PCR has been shown to be positive in about 40% of MS, early MS, especially when they look very specific. Sometimes when you see larger cells in the epidermis, smaller cells in the dermis, again, you can suggest MS, but remember, drugs can look exactly the like. Like especially now with when they have the new monoclonals that they use, no? All of them show MS like this. So it's very hard to exclude MS, and they will never tell you they've started on a monoclonal for psoriasis, for example. So then you will tend to call it MS. So you need that history. Tyrosine kinase inhibitor. That is one big pitfall which we face. So you need to have full history before you can call it in. Sometimes maybe 4, 5 biopsies may be needed before you call it in. We always hedge and hoe and hedge and hoe before we call it in.
So basically, when you have a difficulty, they go for repeat biopsies, meaning, yeah, that's a very good suggestion. I think that should be done. Because these are all, I mean, clinically they look more or less the same, isn't it?
Correct.
Clinically, it's difficult for them.
Correct.
So, like, we have a difficulty, they have a difficulty, then they keep on follow up and take a repeat biopsy after some time. Then the picture maybe becomes clearer, isn't
And
it?
another thing is if the patient is on steroids.
Mm.
So we always tell them 1 month after steroids. So they will see a different picture after a month. Totally different picture.
Also, what happens if they give steroids to a MF, meaning hypopigment, meaning
Patient may actually may be MF, but you may not find the features of MF. You may not find it. So you may undercall it.
okay. And what I asked is that you have this difficulty, and
No, we
do
have
do they give steroids and see the response or something like that?
some, especially a patient comes from, if he's been going a doctor's shopping, or has he been, somebody would have given him some course of steroids. And then they'll tell you the clinical picture is exactly like MF, but we won't see it. So then they say, just do a marker, just do markers, maybe you can fit it in. But you find you cannot fit it in. That's what always happens. You just, what I believe is never fit it into a particular diagnosis unless you're absolutely sure. Because it's a life-changing decision, I mean, diagnosis which we make, So never follow. Just, even if they have to repeat 4 different biopsies, it doesn't matter till you get the right biopsy.
Okay.
Hello.
Yeah.
Yeah, thank you so much, Dr. Meera. Ma'am, I just wanted to bring to notice of our team, I mean the people who are on board, that the certificate option would be available to download. The certificate option would be available post Monday. The registered participants will get email ID, email also. So from email, they can download their certificates directly. And I also request them to, do the links I have posted in the chat box to share the Google reviews. At the same time, I've also pasted a link for YouTube links so that the people who have missed, they can access to the recordings. And at the same time, I also request the team to also join our WhatsApp channel. I've pasted its link also, so we will be able to post further, know whatever upcoming CMEs or webinars are there at the Mindray level.
Okay, thank you, Namrata, for that.
Thank you
And
so much, ma'am.
okay, it was nice to have your
Thank you.
platform. It's always very good.
And I apologize again for the bad quality of the audio and video.
A little glitches we had, but then it was okay because your slides were very good. The cases were excellent. So thank you, Dr. Meera, for that excellent presentation, and you helped us clear many of our doubts. I hope there are no more doubts in the chat box. Shiny,
Yes, there are not much doubts.
we've cleared all the questions also. So thank you once again, Dr. Meera. We hope to associate with you in future also. And thank you all participants. And please be reminded that there's going to be a quiz based on this webinar 5 series conducted at our venue February 9th on February 9th for our IAPM chapter meeting. And there are attractive prizes to be won. So the moderator is going to be Dr. Sheila Thomas. So thank you all once again for joining us. Hope these series were useful to you. I hope it will help you in your practice. Thank you all. Good night.
Thank you, everyone.
Thank you so much, everyone, on behalf of Mindray team. Thank you so much.
Thank you, Dr. Shiny.
Thank you, ma'am.